Thank you. Now we'll go to the next topic by Dr. Abraham Babu from Mangalore. He'll be talking on cardiac rehabilitation, a very important topic, cardiac rehabilitation in pulmonary artery hypertension.
Thank you, sir. I'm here to speak today on cardiac rehabilitation and pulmonary hypertension. These are my disclosures. Exercise intolerance is commonly seen across all groups of PAH, irrespective of their etiology. Our physiologically driven paper showed that various systems are involved, and it's a complex interplay of various physiological changes that result in exercise intolerance. Evaluating these is important from a rehabilitation perspective, as it helps us to understand which system contributes most to the exercise intolerance. Exercise-based evaluations commonly perform this function. And these range from simple functional tests, such as a 6-minute walk test, to more physiologically driven tests, such as the cardiopulmonary exercise test, integrated tests, such as the exercise echo and invasive cardiopulmonary exercise tests. Cardiopulmonary exercise testing has a level B evidence for diagnosis and prognosis, while it has a level C recommendation for gauging therapeutic efficacy. In children, cardiopulmonary exercise testing has been shown to be feasible and safe. The criteria being that children should be at least 120 centimeters or more and be able to comprehend all instructions given to them. And this is extremely important when using a cycle ergometer. The 6-minute walk test is a simple test that can be done in our clinics, and all you need is a 30-meter walkway. Patients are asked to walk for 6 minutes as far as they can, and the distance is measured. Heart rate, oxygen saturation, Boggs rating of perceived exertion can all be monitored before, during, and after the test, and patients have the provision to take a rest if they need to in between. Physical activity is another important assessment that can be done, and it can be done in just 2 simple questions: how many days a week do they exercise and for how long? And that gives the total minutes per week of physical activity. The intensity can also be made note of as light, moderate, or vigorous. When studied in pulmonary hypertension, it was seen by Mathura and colleagues in 2016 that physical activity in adults with pulmonary hypertension was mainly sedentary, and this was from accelerometry data. In children, however, when compared to their age, gender match healthy controls, it was seen that all components of physical activity were much lower when compared to their counterparts. With COVID and post-COVID, cardiac rehab has undergone a significant transformation towards a technology-driven model. And this was what we put forward, where we could use technology ranging from telephone calls, video calls, remote monitoring, sensor-based technology for the delivery of cardiac rehab. Certain tests, which we normally did under direct supervision, can now be done through remote means as well. So why exercise training? What is the need for it? A lot of the physiological mechanisms contributing to exercise intolerance have been shown to respond to exercise training. And these are changes that have been seen in the RV, the hemodynamics, respiratory system, and the peripheral muscles. Most of the changes, however, are seen in the peripheral muscles, and all these together improve function and quality of life of the patient with pulmonary hypertension. In animal models, our lab has recently shown that with exercise, monocrotaline-induced animals didn't lose as much weight as those with PAH who did not exercise. Histopathologically also, we do see that vascular remodeling is lesser in those who did exercise than those who didn't exercise with PAH. The role of exercise training in PAH in adults has been established through various meta-analysis, which have found benefits with exercise training on functional capacity and quality of life, with variable benefits seen in right heart function and long-term outcomes. Our updated meta-analysis, which we have recently completed, shows variations in effect size, and the meta-analysis also shows favoring exercise training, though with a high degree of heterogeneity. The home-based delivery model is a useful way to deliver cardiac rehab programs in the current setting, and in many places across our country where distances hinder patients from coming to our centers. In PAH, however, its use is limited, with only a couple of studies available till date. The hybrid model has been extensively studied, but it is not applicable across most scenarios, especially in low resource settings. In the home-based model, we have followed a program which includes aerobic and resistance training for 3 to 5 days a week at a low to moderate intensity. All the exercises and walking were progressed every 2 weeks, and patients were also given a patient education manual known as the pulmonary hypertension manual. We tested these interventions through a randomized controlled trial on 84 patients for 12 weeks and found that at the end of 12 weeks, 6-minute walk distance improved by 48 meters in the groups receiving exercise training, along with improvements in quality of life and functional class, with no significant changes seen in right heart function. In our meta-analysis, we sought to study whether the site of delivery mattered. And even though we do see the hybrid model showing a greater change, we do see also a change with home-based training with lesser heterogeneity. However, we do need more studies before we can firmly conclude as to which site or which model of delivery matters. What is the duration and what would be the best duration? Well, from our meta-analysis, it is clear that programs of 10 weeks or more did bring about better changes in 6-minute walk distance as compared to programs of lesser than 10 weeks. As to which type of exercises would be most beneficial, there is no clear-cut winner here. All forms of exercises seem to be working, but what we do take from this is that anything is better than nothing, and that some form of exercise is definitely better. In children, the evidence is limited, but we have seen with 16 weeks of home-based training, running distance and quality of life improving in children. With the era of going digital with a technology-driven model, we have postulated its use in patients with pulmonary hypertension from assessment to intervention to monitoring and follow-up. And each of these can be done through various means. So assessments with video calls, phone calls, WhatsApp calls, intervention through sharing of videos on WhatsApp or YouTube links, or even post or email the exercises to them. And monitoring can be done through regular telephonic calls and follow-up as well. With the incorporation of technology into physical activity promotion, a recent paper published in Chest earlier this year found that text-based interventions using short service messages are useful to promote physical activity in those with PAH. And though they did improve the number of steps they walked, as well as other functional outcomes. Based on the etiology, we did postulate that various forms of training would be beneficial. However, at this stage, we still haven't had them tested through specific trials. But nevertheless, it does go to show that anything is better than nothing. To summarize, what I would like to say is that evaluating exercise capacity is important in patients referred to rehab for PAH. Cardiopulmonary exercise testing is the gold standard. The 6-minute walk test is a valid alternate. Remote assessments are available, but they need to be validated for those in PAH. Exercise training is beneficial and feasible, and definitely something is better than nothing. We do need more studies in this area, and we need to focus on technology-driven models, as this will also improve access to rehab to patients across our country. Long-term studies are needed to understand how exercise training can improve various physical and psychological outcomes. And with respect to children, we also need to see how this will impact academic performance. Thank you for your attention. I'll be happy to take any questions.
Thank you, Dr. Abraham.
Thank you, sir.